All right, everybody, here is the nervous system for pathophysiology. So, neurologic diseases and conditions, chapter 13. First thing, just a little bit of anatomy and physiology. So, orderly function of the nervous system. We have a complex network composed of neurons, which are the nerve cells, spinal cord, and the nerves. And then we also have two divisions, the central nervous system and peripheral nervous system. And if you remember back in anatomy and physiology, central nervous system is brain and spinal cord, and peripheral nervous system is everything else. So, outside of the brain and spinal cord is peripheral nervous system. So here we have the structures. This should be somewhat familiar to you from anatomy and physiology or from medical terminology. This is just showing you, we're going to actually talk about this in a few minutes, about quadriplegia, paraplegia, the difference, and it's basically where injury is to the spinal cord. So this is just showing you here what would determine if somebody had an injury with and resulted in quadriplegia or paraplegia. All right, so the neuron, again, this should be familiar. We have the dendrites, we have the cell body and the nucleus, and then the axon. So the axon here is sending the messages out from the cell body, and the dendrites is receiving. So this is sensory, and this is motor. And then the myelin sheath, remember, is kind of like an insulation, and it actually helps for the impulses to travel much faster. And then here's the terminal ends that attach to either muscle, organ, whatever they are sending a message to. All right, so the central nervous system processes and stores sensory and motor information and governs our state of consciousness. So we have the frontal lobe of the cerebrum, controls intellectual functions of thinking, willing, remembering, deciding, and personality. We have coordination, equilibrium, and posture coordinated by the cerebellum, and the hypothalamus regulates secretion of hormones from pituitary gland. So we know when we talk about the endocrine system, the pituitary gland is what we call the master gland, but it actually is under control by the hypothalamus. Then we have the medulla oblongata. It has vital centers that regulate heart rate, blood pressure, and respiration. And so that is a very, very important portion of the central nervous system. So damage to the medulla oblongata could result in death, of course, because heart rate, blood pressure, and respiration are vital functions. And this is just showing you the functional areas of the brain. So when we think about somebody having a stroke or a cerebral vascular accident, depending on where the injury is to the brain determines the outcome. If they have a damage here in the visual area, it could result in blindness. And then frontal lobe, the intellect, personality. And then, of course, it depends on if it's on the right or left side, what area of the body it's going to affect, which we'll talk about in a moment. So neurologic assessment, methods to evaluate neurologic status. So we take thorough medical history, test speech, language, writing skills, and test cranial nerve function, test their muscle strength and tone, test coordination and balance, so when they're walking, and we also do a test called a Romberg test to assess their balance, and then test sensory function. Is it diminished or abnormal sensation? So can they feel sharp, dull, soft touch, firm touch, those types of things for sensory. Peripheral nervous system. So peripheral nerves connect with the spinal cord, and the information they carry travels to and from the brain and spinal cord. So sensory we know is afferent, motor is efferent. So sensory or afferent nerves transport impulses or transmit impulses from parts of the body to the spinal cord and the brain, whereas motor or efferent nerves transport impulses away from the central nervous system and produce responses in muscles and glands. All right, so then we have the peripheral nervous system contains 12 pairs of cranial nerves. And so this is showing you here the cranial nerves, all 12 of them. And then over here you can see some of the just peripheral nerves branching off of the spinal cord. And here's some more. Spinal nerves, we have cervical plexus, brachial plexus, lumbar plexus, sacral plexus. We have all the different pairs. So central nerves, there's 8. Cervical nerves, I'm sorry. Thoracic is 12. Lumbar, we have 5. Sacral, 5. And then coccygeal nerves, there's 1 pair. So, 4 major blood vessels supply the brain with essential oxygen and nutrients. So we have the carotid arteries. There's 2 internal and 2 external, and they're located in the anterior portion of the neck. That's also where you can feel a carotid pulse. Then we have 2 vertebral arterial join with the arteries, join with the 2 anterior and posterior cerebral arteries and the 2 anterior and posterior communicating arteries. And then we have the circle of Willis, which is formed by these arteries. Circle of Willis is very important because it supplies all the areas of the brain with a blood supply. I'll show you a picture in just a moment. So here we have the autonomic nervous system, and the autonomic nervous system, if you remember back in anatomy and physiology or medical terminology, is your, I like to call it your automatic. So it's all those things that you don't have to think about. So it just keeps everything functioning as normal. And then we have the sympathetic division and the parasympathetic division. Here's the circle of Willis. So it shows you 2 different views here. And it's just showing you here the branches here, which feed the circle of Willis, and then how it supplies the brain with blood supply. So nervous system problems, let's get into the pathology here. So we have vascular compromise and circulatory defects and deficits. We have injury, infection, inherited defect, congenital defect, degeneration, and we'll finish up with tumors. So here we have cerebral vascular accident, a CVA or a stroke. So again, it depends on where the blockage or bleed occurs as to where the problem is going to occur in the body. If we have a CVA on the left brain, left side of the brain, it will affect the right side of the body. If we have an injury to the right side of the brain, it will affect the left side of the body. So left-sided paralysis with right brain injury, right side paralysis with left brain injury. And then we also can see speech and memory deficits, cautious and slow behavior with left brain damage, and with right brain damage we have perceptual and memory deficits, quick and impulsive behavior. So there's different types of strokes, which we'll talk about here. If there is a let's say there is a thrombus formation or an embolus, then there's blockage, and then this would affect the portion of the brain. There's also bleeding, where there's bleeding in the vessel, and that's a different type of cerebral vascular accident. So we have common stroke symptoms include sudden severe headache, aphasia, dysphagia, sudden weakness, numbness, and paralysis, sudden confusion or loss of vision, blurred vision, sudden dizziness, loss of balance, or coordination. So one of the things that they'll do to assess for a cerebral vascular accident is have the person, blink, smile, and there will be a drooping on one side of the face. They may not be able to so the face will not be symmetrical. Say, squeeze my fingers. They may not be able to move one side or actually even be able to squeeze their hand together. So CVAs result from occlusion of an artery caused by atheroma, sudden obstruction by an embolus, or a cerebral bleed. So what do we need to do if there's a CVA? We need immediate medical intervention within 3 hours. When we talk about things like heart attacks, we say time is muscle. So the more time that goes by, the more muscle is damaged. It's the same thing with the stroke. So the more time that goes by, the more brain is damaged. So what does this include? Immediate chewing of an aspirin, surgery to improve circulation and remove clots, and surgery to repair broken or bleeding blood vessels, and drugs to prevent or reverse brain swelling. Now, if somebody has a bleeding CVA, we don't want them to take aspirin because that will increase bleeding. But you don't know what kind of stroke it is until they're evaluated. Arteriovenous malformations, these are formed during fetal development. The arteriovenous malformations are abnormal structures in the blood vessels. So although usually found in the brain, they can also be located in any vascular structure. So arterial blood moves directly into the veins, giving the blood vessels the appearance of a tangled mass. And diagnosis is made by assessment of clinical signs and also with imaging studies. Cerebral aneurysms. These are abnormal localized weakening, thinning, or dilation in the wall of the blood vessel. So what happens is because there's a weakness there and it's on the arterial side, it gets larger and it gets thinner and thinner and thinner, resulting in a ballooning of the blood vessel. So cerebral aneurysms often cause no symptoms and go unnoticed until they rupture or leak. So the etiology can be either congenital, which means they're born with it. It could also be from atherosclerosis, hypertension, infection, cancer, drugs, or trauma to the head. Transient ischemic attacks. So these are often called little strokes or mini strokes. And so the person may report sudden weakness, numbness down one side of the body, dizziness, dysphagia, confusion, difficulty seeing with one eye, and or loss of balance. The most common cause of a TIA is a piece of plaque which breaks away from the wall of an artery and travels to the brain. So it's a small plaque embolus. Treatment depends on the location of the TIA and the underlying cause. And so typically with a mini stroke or TIA, the person most of the time will regain normal function. So this is just showing you a small clot or atherosclerotic plaque embolus, and it impedes blood flow. And then what will happen is then when blood flow is restored, they regain full function. So, what are they going to do for a TIA? Anticoagulant therapy may include heparin, enoxaparin, warfarin, aspirin, ticlopyrin, and dipyridamole. So, prognosis varies according to the extent and duration of the ischemia. So, of course, where the embolism has occurred. And then prevention includes positive lifestyle changes to reduce controllable risk factors. So if the person smokes, we want them to stop smoking, change their diet. They may be on cholesterol lowering medications, and then also anticoagulant medications. So instructions should be given concerning possible symptoms of an impeding stroke or impending stroke. So what they typically are going to say, if someone's having TIAs, that could be kind of a precursor to having a CVA. Epidural and subdural hematomas. An epidural hematoma is a mass of blood that forms between the skull and the dura mater, and a subdural hematoma is similar, mass of blood, but it's beneath the dura mater. Symptoms of an epidural hematoma typically appear within a few hours of head trauma. So somebody could, been hit in the head, they could have fallen and hit their head. So typically they'll have a sudden headache, dilated pupils, nausea, and sometimes vomiting, and increased drowsiness. So this is showing you here. Here's the dura mater. An epidural hematoma is above the dura mater, between the skull and dura mater, where a subdural hematoma, sub meaning beneath or below, is below the dura mater. Here's the dura mater here. So what happens is result when blood from a ruptured vessel seeps into and around the meningeal layers. If the person loses consciousness, rapid medical attention is needed. So they'd need a craniotomy, and so they would drill a hole through the skull and release the pressure, drain the blood. If they're not losing consciousness but displaying symptoms, they should be seen as soon as possible, and then provide post-surgical instructions for care of incisions. The person's going to be monitored very closely and be hospitalized. Now, cerebral concussion, we'll talk about here the difference between a concussion and a contusion. So the patient may experience a loss of consciousness, respirations become shallow, pulse rate is depressed, and the muscle tone is flaccid. So cerebral concussion, this is an injury resulting from impact to the head. So it could be from a blunt object, or the person falls and hits their head. We also see cerebral concussions with sports injuries. So treatment would be bed rest, observation for signs of behavioral changes, and prognosis is unpredictable. It depends on the extent of the concussion. So here we have a head injury here. This would result in concussion, so the brain is moving inside the skull. Here is a contusion, so we actually have bleeding of the vessels. So contusion is bruising and bleeding of the brain. So cerebral contusion, symptoms and signs of a contusion vary according to the site and extent of the injury. So when the person's conscious, they may report severe headache, hemiparesis, and appear drowsy and lethargic or hostile and combative. It's caused by a blow to the head or impacting against a hard surface, so falling and smacking the head. And they need to be hospitalized so that their vital signs can be monitored and rapid medical intervention can be available if needed. So a cerebral contusion is more serious than a cerebral concussion, and the two can occur together. So someone can have a cerebral contusion and concussion, of course, at the same time. And here we have closed head injuries. So there's trauma and primary damage. So immediate scalp laceration, skull fracture, contusions, lacerations to this cerebral contusions and lacerations, intracranial hemorrhage, and diffuse axonal injury. And then we have delayed, which is secondary damage, which is from ischemia, hypoxia, cerebral swelling, and infection. Depressed skull fracture is when a piece of the skull actually compresses or pushes into the brain. So a bone fragment pressing on a motor area of the brain may cause hemiplegia. Signs include bleeding from the wound, ears, nose, or around the eyes, changes in pupils, clear or bloody drainage from the ears or nose. And so direct impact on the skull with a blunt object is the most common cause. So they get, hit in the head with a crowbar or a hammer or some kind of weapon. Treatment, craniotomy, and bone elevation to decrease the pressure on the brain, and head protection is worn until the area heals. So here's showing some skull fractures. We have linear skull fracture, and then we have depressed, where the bone is pushed down into the brain, and then comminuted, where there's multiple fragments. And then here's a basilar skull fracture, very, very serious. All of them can be serious. Types of paralysis. Here we have quadriplegia. So this is where the patient's typically paralyzed from the neck down or the upper chest down. So they don't have motor or sensory function in the arms and legs. Hemiplegia, we see usually, this is from, quadriplegia is from a spinal cord injury. Hemiplegia is generally from a CVA, so a stroke. So if there's right side hemiplegia, then it's a left side stroke. If there's right side stroke or CVA, it would be left side hemiplegia. And then we have paraplegia, which is typically from the waist down, and this is from a lower spinal cord injury. So paraplegia and quadriplegia. Paraplegia is loss of nerve function below the waist, resulting in paralysis of the lower trunk and legs. So again, the difference in paraplegia and quadriplegia, it depends on where the spinal cord injury is. So the higher the injury, the more of the body affected. The lower the injury, less of the body affected. Quadriplegia, loss of nerve function below the cervical region, resulting in paralysis of arms, hands, trunk, and legs. When the spinal cord is injured, a part or parts of the body inferior to that point of injury may be affected. So remember, when the spinal cord is injured with paraplegia and quadriplegia, they're going to have loss of motor and sensory function. So they can't move the area, they also can't feel it. So symptoms, paraplegia, loss of motor and sensory control in lower extremities and trunk, as I mentioned, loss of bladder, bowel, and sexual function. Quadriplegia, loss of motor and sensory control in the upper and lower body, hypotension, hyperthermia, bradycardia, and respiratory problems. Some people with quadriplegia will be on a respirator or ventilator. So the spinal cord injuries that cause paraplegia and quadriplegia are a result of vertebral fractures or vertebral dislocation, can cause severing. So trauma to the thoracic and lumbar regions of the spine, T1 and below, Usually result in paraplegia. Trauma to the cervical vertebrae, C5 or above, may result in quadriplegia. And treatment, restoration of normal alignment and stability of the spine, decompression of spinal cord, and early rehabilitation. Some people with compression on the spinal cord may regain function. If there's severing of the spinal cord, they will not regain function. So here's some spinal cord injuries here. We have compression fracture here at L1, and this is from falling, direct compression on the spine. A cord a distortion, torn posterior longitudinal ligament. So this is hyperflexion. We usually see these in automobile accidents. And then cord compression, torn anterior longitudinal ligament. And this is from falling, and so there's extension here. So here we have flexion, here we have extension. All right, effects of spinal cord damage. This is just showing wherever there's injury, and then there's going to be the damage below that. So they're just showing cervical injury, total block, cervical injury and inflammation, and then of course here lumbar injury. All right, degenerative disc disease. Here we have pain occurs. It radiates down the nerve path and may be described as burning. It can also become intractable, may be accompanied by loss of some motor function in the leg. So it's a kind of a shooting pain. As the person ages, the water or fluid in the disc decreases and causes degenerative disc disease. The present treatment includes advising the patients to be as active as possible. Treatment of degenerative disc disease, narcotic analgesics and NSAIDs, or non-steroidal anti-inflammatory medications, oral steroids, epidurals, or selective nerve root blocks, physical therapy, and surgical intervention might also be necessary if it progresses. And when surgical intervention is not an option, they may have lidocaine topical patches prescribed for the area for pain. One of them is called Lidoderm. Transcutaneous electrical nerve stimulation is also called TENS, TENS units, and these deliver small small electrical impulses that are transmitted to the surface of the skin through electrodes. And so the TENS units and non-drug therapy option permit many with chronic pain to return to fairly normal lifestyles. TENS units may also be ordered for pain relief of chronic back pain, spinal stenosis, sciatica, arthritis, and postherpetic neuralgia. Herniated and bulging discs. This is where each where each of your intervertebral discs act as a shock absorbing cushion between the vertebrae, and it gives the back its flexibility as well, so there's not bone against bone. So what happens with a herniated or bulging disc is the nucleus pulpus that's contained within the annular wall in the bulging disc, it begins to push through. So the rupture can cause severe back pain and even disability if it presses against or pinches the spinal nerves. Most herniated discs occur in the lower back, and that's because, so in the lumbar spine. And that's because that's where, when we're lifting, they're usually from lifting or stretching type of injuries. So here you can see the disc is bulging out and it's compressing the spinal nerve. So here is a lateral, and then here we have posterior. Same picture. So herniated and bulging discs, the intervertebral disc usually result from accumulated trauma, usually from overuse or lifting incorrectly. Physical examination of the back is performed to rule out other possible causes of their symptoms, and then conservative treatment consists of use of hot or cold packs and the administration of muscle relaxants and analgesics, and the prognosis basically depends on the extent and duration of the herniation. Sciatic nerve injury and spinal stenosis. So rupture of one or more discs or their nuclei produces severe sharp pain, and it shoots or radiates down the sciatic nerve, down the leg and to the foot. The pain can be continuous, so there all the time, or it could be intermittent. And trauma to the sciatic nerve may result from a fall, poor body mechanics, gunshot, or stab wounds as well. So, what is the treatment? Strengthening core muscles after inflammation subsides. So, the abdominal muscles, medications, so analgesics for pain, muscle relaxants, anti inflammatories, and sometimes they will use narcotic medications for pain. Physical therapy may help relieve some of the pain, and corticosteroid epidural injections may relieve pain and reduce inflammation. And then, in some cases, surgical intervention. Headaches. Headaches can be acute or chronic and located in frontal, temporal, or occipital regions of the head, so basically anywhere in the head. The type of pain may vary from dull and aching to almost unbearable, and there are very different types of headaches. So brain tissue themselves never ache because they don't contain sensory nerves. So your brain basically doesn't have sensation, is sometimes a symptom of an underlying disorder or disease. So, headaches can be caused, there's several types of irritation factors. The first cause is strain of facial, neck, and scalp muscles, and that's from tension. So, tension headaches. The second cause is edema within the blood vessels of the head, and the cause of headache determines the type of treatment chosen. So, no underlying cause, usually pain medications, muscle relaxants, minor tranquilizers, muscle massages, and relaxation. So, a migraine, this is a vascular headache. So, warning signs include visual auras and photophobia. So, these are kind of are what we call um, things that occur before the pain actually develops. So patients may have this onset of seeing weird colors or lights. They may be very sensitive to light, and then they start developing the pain. They may feel abnormally tired and irritable. They may have numbness or tingling in one arm or one side of the body, dizziness, and temporary mental confusion. It's not known why some people have migraines and what triggers them, but there is consideration that it's inherited or a genetic aspect. Treatment of migraines, bed rest in a quiet, dark room, pain medications, drug therapy. So we use vasoconstrictors to constrict the blood vessels because with migraines, the blood vessels dilate. Antiemetics to control vomiting, nausea and vomiting, triptans, relaxation therapy, and then biofeedback therapy as well. Epilepsy. This is a seizure disorder. So epilepsy takes many forms and has a variety of manifestations. Generalized seizures cause diffuse electrical abnormality within the brain, and this includes absent and also tonic-clonic attacks. Tonic-clonic may begin with the person may, make weird sounds. They fall to the ground, loss of consciousness. This is where they are shaking. And then there's also a condition called status epilepticus, where one seizure follows another. There's no recovery of consciousness between attacks. The absent seizures, that's when the person typically they don't have the convulsions. They just may kind of zone out for a few seconds to minutes. So in idiopathic epilepsy, there's no apparent cause for the abnormal electrical discharge. In symptomatic epilepsy, a known abnormality in the brain is what causes the seizures. And then anticonvulsant medications are the treatment of choice for epilepsy, and then close monitoring. And of course, people with epilepsy are not going to be able to drive automobiles. First aid for seizures. What you want to do is move anything out of the way that the person could, injure themselves on. And so, move chairs, desks, furniture out of the way. Never hold the person down. Do not put anything in their mouth. Do not give them anything to eat or drink. When someone recovers from their seizure, what may happen is they may vomit, they may urinate, or they may defecate. So what you want to do is after the seizure is over, loosen any tight clothing, turn the patient onto their side in case they vomit, generally the left side. Put some clothing or a pillow or something under their head. They may be very confused. Offer help. If the person is very, confused or really out of it, it may be a 911 situation. Parkinson's disease. Symptoms may be associated with aging until the recognizable paradigm of Parkinson's disease emerges. So you may just say, oh, they're just getting older until we actually identify it. A primary symptom is a tremor or trembling in the hands, arms, jaw, face, and legs. There is a rigidity or stiffness of the limbs and the trunk, and it causes the posture to be stooped. So they have a kind of a stooped over, and then they have a shuffling gait, which means they walk in a shuffling pattern. What causes the degeneration of the nerves and motor system in the brain is not known, so the etiology is unknown. Here's the posture and gait. So you see that they're kind of hunched or stooped over, tremor generally in the hands and the arms, and then this shuffling gait. Diagnosis is based on the characteristic history and careful neurologic examination, and treatment is individualized to the patient. So Parkinson's disease cannot be cured, so there is no cure. There's just some treatment, hopefully, to delay some of the progression. Medical management consists of supportive measures and control of symptoms with the administration of drugs. Physical therapy helps the patient maximize mobility within the limitations. Huntington chorea. This is a horrible, horrible disease. It has an insidious onset with the loss of musculoskeletal control, exhibited by subtle, semi-purposeful movements. The arms and the face are the first areas to be involved, with movements ranging from mild fidget to tongue smacking. Disruption in personality and personality changes may occur, and this is transmitted by an autosomal dominant trait that can be inherited by either sex. So it is a genetic trait that is passed on. Treatment of Huntington chorea. The treatment is supportive, symptomatic, and protective. There is no cure for Huntington chorea, and some of the medications are Haldol and Prolixin are prescribed in an attempt to control the choreatic movements and to reduce agitation. Amyotrophic lateral sclerosis, or ALS, also called Lou Gehrig's disease. What it causes is fasciculations and accompanying atrophy and weakness are noted in the forearms and the hands. These patients progress to having difficulties in speech, chewing, swallowing, and breathing, and eventually they need a ventilator. Although the etiology of ALS is uncertain, some causes may be autosomal inherited traits, but the etiology is unknown. Treatment of LAS, of course, is supportive. Treatment involves a team of caregivers to provide supportive measures and therapy directed at controlling symptoms. There is drug therapy and other medications to reduce fatigues, spasticity, pain, sleeping difficulties, and excess saliva. Restless leg syndrome. There are feelings often described as an itching, burning, jittery, or creepy crawly feeling, pulling or tugging feeling, and or painless sensations in the legs. The inability to sit for extended periods of time. This also occurs at night when people are trying to fall asleep and they feel like they have to continue to move their legs. The exact cause of restless leg syndrome is unknown, and a blood test may show low blood iron content, and treatment involves identifying the underlying cause of the disorder and treating that. Transient global amnesia. The learning process is completely blocked and the memory disturbances are involved. So the person may ask, repetitive questions such as, where are we going? Why are we going there? Where am I? Why did we do that? Are typical questions. Usual tasks are performed without difficulty and neurologic signs are normal. The etiology is unknown and treatment is just supportive. Peripheral neuritis or neuropathy. This is unless the precipitating factors are severe, infection or chronic alcohol intoxication, the onset is insidious. So clumsiness and loss of sensation in the hands and feet are followed by flaccid paralysis and a wasting of muscles in these areas. Deep tendon reflexes become diminished and tenderness is noted in the atrophied muscles. And there are several causative factors for peripheral neuritis and neuropathy. Treatment of peripheral neuritis and neuropathy. Eliminate exposure to toxic substances if that's the cause. Correct any nutritional deficiencies if that's the underlying cause. Control the disease. Patient must avoid all alcohol of any form, and administration of anticonvulsants and tricyclic antidepressants and physical therapy. Trigeminal neuralgia, it's also called tic de la rue. That's a term that's often mispronounced, so tic de la rue. Transient excruciating pain of the trigeminal neuralgia radiates along the fifth cranial nerve. That's where it's distributed, and it can be in three separate branches of the trigeminal nerve, wherever the inflammation or the pain occurs. So when the ophthalmic branch is affected, pain is experienced in the eye and the forehead. When the maxillary branch, this involves the nose, upper lip, and the cheek. And when the mandibular branch is involved, it's the lower lip, outer portion of the tongue, and the area of the cheek close to the ear. So depending on which branch would determine where. And, in worst case, it could be all areas, which would be really excruciating. So here's showing the trigeminal neuralgia. It's an ophthalmic branch, maxillary branch, and then the mandibular branch. So it would be affecting these branches. So cause is uncertain, although some cases have been found to be related to compression of the nerve root by a tumor or vascular lesion. Pain medications are prescribed, and then recent drug therapy includes the use of anticonvulsant drugs as well. Muscle relaxants may also be effective. Bell's palsy. So this should have an S. This actually is spelled wrong. It's not Bell palsy, it's Bell's palsy. The patient may be aware of pain or drawing sensation behind the ear, and then inability to open or close the eye, and drooping of the mouth and drooling of saliva. So you don't want to confuse this with a CVA or stroke. So that CVA or stroke would affect the entire side of the body, whereas with Bell's palsy, it's generally the head, neck, and sometimes maybe the shoulder area. The patient is unable to smile, whistle, or grimace, and the facial expression is distorted. Taste perception may also be diminished, and the cause of Bell's palsy is not always certain. Some people recover completely, and others may suffer from these problems lifelong. So here you can see the forehead does not wrinkle on this affected side. They're not able to move their eye or close their eyelid, and flat nasolabial fold and paralysis of the lower face. Treatment of Bell's palsy: warm, moist, gentle heat and massage, facial exercises to stimulate muscle tone, prednisone to reduce edema of the facial nerve, analgesics, so pain medications, artificial tears and an eye patch, and electrotherapy to stimulate nerves and prevent atrophy of the muscles. So differences between Bell's palsy and trigeminal neuralgia. So you don't want to confuse these two either. Bell's palsy is a sudden paralysis. Motor function is impaired. They still have sensory function, and most of the time. Sometimes it's affected, and prognosis is good if treated early. Trigeminal neuralgia is extreme pain. There's no motor function impairment, so there's no paralysis, and the prognosis varies depending upon the cause. Meningitis. So early symptoms of meningitis include vomiting and a headache that increases in intensity with movement or shaking of the head. Deep tendon reflexes increase, and the patient exhibits irritability, photophobia, and a hypersensitivity of the skin. They also develop nuchal rigidity, which is a neck pain. So when they bring their chin down to their chest, it causes excruciating pain. It's called nuchal rigidity, and it's very difficult. It's very painful, and their neck is rigid. Meningitis can be either bacterial or viral. Here's bacterial meningitis, which is the more severe type of meningitis. So viral meningitis, they may have kind of flu symptoms and the meningitis symptoms, and may have full recovery. Bacterial meningitis, if not treated, is deadly. So treatment: aggressive antibiotic therapy, anticonvulsive drugs to control seizures. Glucocorticoids may be administered to reduce cerebral inflammation and edema. Aspirin or acetaminophen for headaches, and dark and quiet environment. Encephalitis. Let me also mention there is a meningococcal vaccine, which is given to children and teens around 12, about middle school age is when they give it. And so it's an important vaccine. This meningitis will spread very rapidly, especially in crowded areas, and death can occur within 2 to 3 days if not treated. Encephalitis may have an insidious or sudden onset. Primary symptoms include a headache and elevated temperature. The patient experiences a stiffness in the neck and the back, muscular weakness, restlessness, visual disturbances, and lethargy. It can be caused by viruses, toxins from chickenpox, measles, or mumps, and it can also be caused by a bite from an infected mosquito. There is a great movie called Awakenings, which stars Robin Williams and Robert De Niro, and so it talks about kind of this condition. If you've ever seen the movie, you'll know what I'm talking about. If not, it's a movie you should watch. But this was the symptoms were caused by an encephalitis outbreak. Treatment of encephalitis. Antiviral agents are effective against herpes simplex encephalitis. Otherwise, mild analgesics for pain, anticonvulsants, antibiotics for any present infection, bacterial infection, of course, and stress the use of mosquito repellents when in an outdoor environment for prevention. Guillain-Barré syndrome, this is also a term that is mispronounced often. It looks like Guillain-Barré, but it's pronounced Guillain-Barré syndrome. An individual experiences numbness and tingling in the feet and the hands at the onset of the disease, followed by increasing muscle pain and tenderness. Progressive muscle weakness and paralysis usually start in the lower extremities and move up the body. The syndrome is thought to have an autoimmune basis. Treatment of Guillain-Barré. Hospitalization is required for observation. Plasmapheresis washes the plasma to remove antibodies, thereby shortening the time required for recovery. And then intravenous human immunoglobulin may also be beneficial, and there's no method of prevention. A brain abscess. So primary symptom of brain abscess is headache. So an abscess is an abscess. So it just depends on where it is, what we're going to call it. So it's an accumulation of pus. So the symptoms and signs depend on the location and extent of the abscess. So where it is in the brain and how large it is. Central nervous system abscesses may be the result of a local infection and may be secondary to infections elsewhere in the body. So here's showing the encapsulated brain abscess. So they may have to go in and drain the abscess and then, of course, start antibiotic therapy. Bacterial infections of the central nervous system, it could be from the frontal sinusitis, so sinus infection that actually then goes into the brain. Penetrating trauma, so something penetrates the brain and inoculates it with bacteria. And it could also be from spread, the hematogenous spread from the blood, and then middle ear otitis media and mastoid sinusitis, so mastoiditis, which then migrates to the brain. Treatment of the brain abscess, intravenous antibiotics, mannitol or steroids to reduce cerebral edema, surgical drainage of the abscess to relieve pressure, and the prognosis varies depending on where the abscess is, the size of it, and the causative agent of the abscess. Poliomyelitis and post-polio syndrome. A patient with poliomyelitis will have a low-grade fever, profuse discharge from the nose, and malaise. So really runny, purulent drainage from the nose. The symptoms are followed by progressive muscle weakness, stiff neck, nausea, and vomiting, and flaccid paralysis of the muscles involved. We don't really see polio, although there have been some resurgence of polio outbreaks because we thought we had eradicated polio with the polio vaccine, but unfortunately we have seen some polio cases in the last few years. Poliovirus enters the body through the nose and throat and crosses into the gastrointestinal tract and reproduces in the lymphoid tissue. Treatment of poliomyelitis and post-polio syndrome. Pain medications, moist heat, bed rest, physical therapy, leg braces, mechanical ventilation, and then there is also the vaccine available which grants immunity to only one form of polio. Intracranial tumors or brain tumors. So tumors can be primary or secondary. So primary tumors arise from any cell within the central nervous system. Regardless of the tumor cell type, symptoms and signs result from displacement and compression of normal brain tissue by the tumor. So brain tumors are classified histologically according to the predominant cell type. So here's a brain tumor. So even if a brain tumor is benign versus malignant, we know malignant can metastasize, and that's horrible. They grow rapidly. But a benign tumor, even though it's encapsulated, does not metastasize and generally are slower growing. The problem is that they displace normal brain tissue. So increased intracranial pressure, and this is again from displacement of the brain tissues. This is just showing you all the different types of tumors and the type of pressure that they can cause. So evaluation of a patient with a suspected brain tumor includes a detailed history, neurologic examination, and diagnostic neuroimaging studies. And although brain tumors can be malignant or benign, the distinction is blurred in the brain. Treatment: primary tumors, surgery, radiotherapy, chemotherapy, and immunotherapy, or immunotherapy. Treatment for secondary tumors. So that means that there's a cancer or tumor somewhere else that is metastasized now to the brain. This focuses on relief of the neurologic symptoms and long-term tumor control. Patients with solitary brain lesions and no other sites of metastases undergo surgery. Whole brain radiation therapy is also a therapy, and no methods are known to prevent intracranial neoplasms or tumors. Prognosis: the 5-year survival rate for all types of brain tumors combined is 32%, which is among the lowest for all types of cancer. So someone with a brain tumor, the survival rate is somewhat low. And that is it for Chapter 13. I hope this was helpful.